we Yes, sir, we can begin now.
Okay. Can you put the first slide? Can you share the screen? Can I start? Hello?
I'm good, Kedar. I mean,
No. He's
Yes,
supposed to
sir, we
share,
can begin. We can begin, sir.
but I
I'm
need
sharing the
my.
screen then.
Yeah, please share the screen. Then I'll start.
Okay. Then, sir, we can begin.
Yeah. Okay. So welcome all. On behalf of Team ISAR 2021, I am Dr. Kedar Ganla. I welcome you all for a series of webinars organized by Zydus, which are held by DocMode. Today's speaker is a very renowned doctor from Calcutta, young dynamic doctor, Dr. Rajeev Agarwal, who is a laparoscopic surgeon and a clinical director of Care IVF Center in Calcutta. Now, he has done his IVF from, learned from none other than Dr. Sadhna Desai, and he has also done his observership at Cardiff Assisted Center, Wales. Also, Rajiv has been associated with Dr. Pratap Kumar for a period of time in Manipal University. Two good things about Dr. Rajiv Agarwal is he published this book called Decision Making in Infertility. It's an excellent book. It's a form of ready reckoner book which can be used for daily practice in the form of diagrams and flow charts rather than big lengthy statements. And second is he and Dr. Apurva Palam Reddy are the one of the first one to start this international fertility academy, which is online and offline learning, which is learn the best from the best at your convenience. I wish you, Rajiv, all the very best, and you may start. And that's Rajiv's lovely family.
is my screen visible to everyone? Hello? Hello?
Yeah, hello, doctor. Just put it to slideshow, sir.
Right. Thank you, Dr. Kedar, for that wonderful introduction. And at the outset, I would like to thank Isar and, of course, Dr. Kedar Ganla for giving me this opportunity, for Zydus for backing me up so well and for giving me this platform, and, of course, Doc Mode for the IT backup. And it's a wonderful platform, makes presentation so very easy. So, friends, today we're going to discuss about how to improve the success rates of IUI. Now, obviously, when we talk about ART procedures, we talk about intrauterine insemination as a very basic procedure from wherein we progress to IVF. And this is always the transition that most patients and doctors like as well, unless there is a particular reason for us to jump into IVF directly. Now, although IVF has been around for years together, yet when we speak on forums, we speak about colleagues, etc., the most common point which comes forward from gynecologists is the success rates are extremely poor. And it's very disheartening that we do so many IUIs, but pregnancies don't come. Is it even worth doing something like that? And sometimes sometime in between, the NIC guidelines as well came and said that IUI is really not worth it. You probably should not do an IUI, and you should move on to an IVF directly as and when time demands. Is this really true? Is IUI really such a bad process or not so good a process? So, G. Bahadur et al. Wrote a very nice letter to the editor of Human Reproduction, saying that the nice guidelines said that IUI is not a very good procedure based on just one single randomized controlled trial done by Bhattacharya et al., wherein he said the pregnancy rates are no more than 6%. Of course, that very same year, the mean pregnancy rate of 13% per IUI per cycle was reported in UK. So was Dr. Bhattacharya's figure absolutely off the mark? G. Bahadur wonders. He also said that a majority of the assumption in the NICE guidelines was that multiple pregnancies happen in IUI, and that is not acceptable. Again, G. Bahadur says that what he took was as clinical pregnancies and not live births. And we all know that there are some patients who may get pregnant with twin pregnancies as clinical pregnancies, but some of them do turn out to be vanishing twins, and it turns out to be a natural selection into a single pregnancy. So probably taking live births would have made his study a little more authentic. Again, since it was said that having 2 to 3 follicles in an IUI, which we know improves success in an IUI, then the chances of a multiple pregnancy happen. The argument against it, of course, is we know that most IVF centers will at least transfer 2 embryos, if not 3. In earlier days, we were even transferring 4 and 5. I don't know how many centers would really be transferring a single embryo, at least in India, unless a PGS or embryo biopsy has been done. So if 2 or 3 embryos being transferred in an IVF does not cause so many multiple pregnancies, then how can 2 to 3 follicles being created in an IUI really create that many multiple pregnancies? Then we should all move to, as a rule, a single embryo transfer, which is good, which is right, but probably not always achievable, at least in the Indian settings. And he also said that shifting from unifollicular to bifollicular IUI cycles will potentially increase the chances of pregnancy by 3.4-fold, which does make sense in an Indian setting again, because the pregnancy rates are improving, yet the cost, because of IUI being on the cheaper side, does not increase too much. So, which is, of course, a fantastic thing. And he goes on to showing his own study, wherein he said that a pregnancy rate of 20.1% per cycle was achieved, such that 34% of women could expect a pregnancy. And in women below the age of 35, 39% of the cohort got pregnant, which is fantastic. How much more pregnancy rates can you really expect from an IUI cycle? So why is IUI so popular? Of course, as I said, it is the first line ART procedure, simple and non-invasive. It is economical, and IUI really hardly costs anything at all. There are centers which do IUI for absolutely nothing at all. Lack of serious complications. It's a very simple process, can be handled by most gynecologists in their clinic as well. Sometimes they have the semen preparation done in an IVF center, and the sample is sent out to them. And in their clinic itself, IUIs can be done. So it's a there are no major complications with an IUI. It does improve the cumulative pregnancy rate. So if some patients can get pregnant with an IUI alone, why push them into an IVF? Like the Western world, we are neither government funded nor insurance funded. And of course, it increases the gamete density at the site of fertilization. How do we increase this success rate of IUI? Or are we making a mistake somewhere? So the average rate or success rate of an IUI varies from 7 to 25%. And this would depend on taking the ideal couple, using the right kind of oral ovulogens, using the right kind of GnRH analogs, or ovulogens can be gonadotropins as well, using the right kind of trigger, probably looking at the right endometrial thickness, if at all that is important, looking at the right endometrial pattern, if at all that is important. Of course, the technique of preparation. Does semen preparation technique influence the success rate of an IUI? What is the technique of insemination? Does that influence the success rate of an IUI? What is the timing? How many should we be doing? And what is the ideal time for doing it? And of course, a single or a double IUI. Who are the ideal couple for whom an IUI should be done? So honestly, when we talk about enhancing success rates, it's not something which is a magical wand that you wave over someone's head and pregnancy happens. Ideal success or good success rates will happen by you following certain protocols, choosing the right kind of patients and working on them in the right kind of manner, and that is how you're going to improve your success rates. So, who are the ideal couple? In looking at the female factors, we should probably be looking at age, we should be looking at the duration of fertility, we should be looking at the tubal factor, and of course, we should be looking at the ovarian reserve. If the ovarian reserve of that patient is not very good, why would you even want to subject that patient to an IUI cycle? When we come on to the male factors, the total motile sperm count should be taken into consideration. And a factor which has been emerging over the last couple of years is that the DNA fragmentation index. So that should also be taken into consideration. And of course, there are some unexplained factors where we don't know what is going wrong. Uh, Probably IUI might just play a role over there. Let us start looking at these factors one by one. What about age? So, if there are various studies all over the internet talking about prognostic factors in intrauterine IUI cycles, you can go up and Google any one of them. And this particular study says that if only age were taken into consideration, a lower age definitely makes more IUI success than a higher age. And even in this particular analysis, you see of 2019 cycles, which is a huge number of IUI cycles to do. And when they looked at the prognostic factors, especially using husband sperms, they found that as the age of the patient increases, the IUI success rate starts to go down, being almost 17% in the age of 20 to 30, going down to just 5.4% or 3% above the age of 40. So age is a huge factor or prognostic factor for enhancing success rates of IUI. What about the duration of fertility? Does it really matter? Someone comes to you after 7 years or 8 years of infertility, probably does not have any other problem. Would this patient do any worse or better or equal to someone who's been married for, say, the last 3 years? Again, it has been shown that more the duration of infertility, for some reason, the success rates of IUI tend to go down. And they came up with an analysis saying that if the duration of infertility was less than 4 years, the chances of IUI success would be higher. The message to take home from here is that if you have a patient, do not keep them on timed intercourse for the longest possible time. Because you know, after 4 years of infertility or after 4 years of trying, the chances of success, even with an IUI, would reduce. So probably it would make sense to push them into IUI earlier than later. What about the total motile sperm count? Now, total motile sperm count again is very, very important. Ideally, at least after washing, 5 to 10 million sperm should be available. That is ideal. So if you have that much, you can go ahead and do your IUI. Of course, there are enough literature which say that even 1 million of sperms being present should not be very bad. We will be coming a little later and talking about where you should be using this 1 million. Do all patients who have a 1 million count should be put into an IUI, or should we apply more filters and more criteria before we utilize this 1 million? DNA fragmentation index, or DFI. I remember very well when I used to have this discussion with my andrologist, I would say maybe about 20 years back. And the talk about DFI was just about starting at that point in time. And I spoke to him about should we be doing a DFI? He said there is no point because DFI does not give you any information and DFI does not help you in your treatment. And there is no way you can improve the DFI. So, what is the point of even testing it? We know today that DNA DFI is very, very important. It is important in terms of two methods, or rather three methods. One, it tells you whether you should do an IVF or other higher forms of assisted reproduction techniques. Within assisted reproduction techniques, should you be doing an IVF or you should be doing an ICSI? Between that as well, if you're doing an ICSI, should you be taking the ejaculated semen sample or should you be actually going ahead and taking the sperms from the testes directly if the DNA fragmentation index is more than 50%? So that is how important the DNA fragmentation index is. And it has again been shown that if the DFI is less than 15%, the pregnancy rates are as high as 41%. So again, do look at the DNA fragment in the DFI wherever you are in doubt with probably a not so good sperm quality. You might just be able to push these patients to an IUI earlier. A, B, if the DNA fragmentation index is very poor, then you understand that IUI may not be the right treatment for them, and they probably should be pushed into an IVF or an ICSI. What about morphology? Again, they say that if there is one factor that you should be looking at in a semen analysis, it should be the morphology. And that would probably be the most important deciding factor in giving you a pregnancy, whether it is IUI or IVF or even a natural conception. So here is an algorithm wherein we say that there is a male factor subfertility, there is either no tubal factor or there is a tubal factor. If there is a tubal factor, there is no point in even discussing. You have bad sperms, you have bad tubes, please go on to IVF or ICSI directly. In fertility practice, 1 plus 1 makes 11. So do not try and fight on two sides simultaneously. Try and limit your fight to only one factor, either in the male or in the female. So male factor along with tubal factor, going for an IVF or ICSI directly. What about no tubal factor? So then you look at the inseminating motile sperm count. So once you've done your semen preparation, you've got all motile sperms now, and then you start looking at the count. So if the motile sperm count is less than 1 million, but the morphology is more than 4%, you might try IUI for 3 to 4 cycles. And if it works, fantastic. Otherwise, going for an IVF or ICSI. But even if the inseminating motile count is more than 1 million, but the morphology is less than 4%, do not waste your time. This patient may not do well with an IUI cycle. It is better to proceed to ICSI directly, not even an IVF. So these are again learning points for us to understand how to enhance our IUI success. As I said, and we've all been taught in our medical days, while it is important to know what to do, it is probably more important to know what not to do for a patient. And sometimes better things arise not out of doing something for a patient. It arises out of not doing certain things for a patient. If you push the patient into a wrong treatment, there is every possibility that this patient may not get pregnant with an IUI cycle. And then the fault does not lie in the IUI treatment. The fault lies in our recruitment and pushing the patient into a wrong treatment. So remember, 4% morphology. And again, a lot of our colleagues, friends, for some reason are still not following the Kruger strict criteria in looking at the morphology. We are still sending our patients to normal pathology labs where they're still reporting 70, 80, 90%. The problem which happens is when you get such a report from a patient and the patient sits across your table and you don't know what to do with them because it's 80% morphology normal, wherein the same patient probably being sent to an infertility center will give you a morphology of 3%. Your diagnosis, your treatment, your whole outlook towards that patient changes. So do modify to the latest criteria of looking at morphology, which is the Kruger strict criteria. Now, this is a very interesting concept, which is the modified Hunault model of natural conception. Now, this model takes into consideration various aspects of women's age, duration of subfertility, the FSH level, the BMI, pregnancy history, and so on and so forth. What does it do? It gives a point for each of these factors. And it says, let's total the points at the end of it. Now, the higher the points, the more are the chances that this person or this woman will conceive naturally in the next 1 year. How can we apply the same model to an IUI perspective? We will see just in a short bit. So, which is an ideal couple? If we summarize all that we have learned in the last couple of minutes, the female should be less than 35 years. The duration of infertility should be less than 4 years. It should be unexplained ovulatory or secondary infertility or mild endometriosis. The basal FSH should be less than 7. Of course, we know that FSH levels are slowly being given up, and we are now moving to more AMH levels being taken into consideration. The tubes should be patent. Please do not do an IUI without doing a tubal patency test. Please remember that as a couple, every couple has the right to try even for 15 years without ever doing a tubal test. It is their life, it is their body, it is their problem. But as a doctor, when we are doing a procedure for a patient, it is our liability, it is our duty, and it would be morally wrong, it would be medically wrong, it would be legally wrong if we've not tested tubes for this particular couple before subjecting them to an IUI. Where you could possibly not do a tubal test is maybe for one cycle if the husband has azoospermia or for whatever other reason you're using donor semen sample and you see that the wife has absolutely normal factors, she's a young woman, after having counseled them, that look, I'm not doing a tubal test for you because your husband has a very definitive factor. Maybe you could conceive in one cycle. And if you want, then I can skip one cycle and do the tubal test in the second cycle. That probably is the only area where you may not do a tubal test. And we also know that tubal test is not only about legality, it is not only about morality. It is also that if you take two groups of 100 patients, in one group you do not do a tubal test, and in another group you do a tubal test. And by some divine intervention, you already know that in both group of 100 patients, the tubes are actually all right. In the group that you do a tubal test, pregnancy rates are higher. Probably by the act of flushing the tubes, uh, somehow the pregnancy rates become much better. So it's very important that we do a tubal test. The total motile sperm count should be 5 to 10 million per ml. Morphology should be more than 4%. The DFI should be less than 30%. And the Hunold model of natural conception score should be less than 30. Because if the score is more than that, then these couples could as well try normally as well. Coming down to ovulogens. Should we at all use ovulogens? Which ovulogens should we use? And do we need to use only oral? Do they work? Because we are trying to keep the cost low. Should we add gonadotropins? And if we do add gonadotropins, how do we add gonadotropins? So clomiphene versus letrozole, especially in unexplained infertility. It's been shown that the pregnancy rates are much better with letrozole therapy as compared to clomiphene therapy. The pregnancy rates are better, and of course, the twinning rates seem to be more or less similar. Of course, it's not significant, but the pregnancy rates are definitely much better with letrozole therapy. One study even went so far as to say that if you use letrozole and timed intercourse, not even doing an IUI, it is better than doing clomiphene and an IUI. So if you're doing clomiphene and an IUI, you're having a lower success rate than just giving the patient letrozole and saying, go back home and try natural intercourse. What about mild endometriosis? We know that in endometriosis as well, a lower estrogen state would be better. So in that respect, letrozole probably should fare better than a clomiphene citrate. However, studies have not always shown what this way. Of course, there are some studies which have said that in endometriosis, IUI, letrozole fares better than clomiphene citrate. But to be very honest, most studies have said that clomiphene citrate and letrozole are absolutely the same. What about polycystic ovarian syndrome? Because in endometriosis, a lower estrogen state was favorable, and in women with PCOS as well, we know that a higher um, uh, estrogen levels are present. And if we lower the estrogen levels, would probably have been better. So does that mean that in PCOS women as well, both are same? No. Unfortunately or fortunately, letrozole works much better in women with polycystic ovarian syndrome as compared to those with clomiphene citrate. So it appears to improve both the live birth as well as the pregnancy rates in some fertile women with PCOS. What are the factors which favor letrozole? We know that it produces monofollicular genesis. The E2 levels are on the lower side, which is a very good thing. The lower E2 levels are, of course, much better because we know that higher E2 levels, even in an IVF, reduce the implantation rates. The endometrial thickness is much better with letrozole. We know that the ovulation rates with clomiphene are 80%, but the pregnancy rates are only 40% because clomiphene citrate has a negative impact on the endometrial thickness. What about clomiphene versus HMG? Now, it's been shown that when you compare with ovarian stimulation with CC, HMG stimulation was characterized but by a much higher pregnancy rate as compared to clomiphene, which is quite obvious. I think it was unfair of us to even make this comparison. So HMG is much better than using clomiphene. What about again clomiphene alone or clomiphene with gonadotropin? Which one is really better? Again, it's been shown that when you use gonadotropin alone or clomiphene with gonadotropin, it is much better than using clomiphene alone. So the point to take back home from here is that maybe clomiphene or letrozole, whatever suits your fancy, start with that, but move on to gonadotropins as soon as possible. I always say that you're not going to do more than maybe 3 to 4 cycles of an IUI for any patient. Look at it from having maybe 3 to 4 bullets in your gun. You're not going to fire those bullets randomly if you know that if you have only 3 bullets in your gun, you will aim and shoot each bullet very, very carefully, making sure that each bullet counts. Similarly, for IUI as well, you need to make sure each IUI counts. So probably you can start with oral ovule agents, but if the first cycle fails, you can move on to adding more and more gonadotropin because they definitely improve your pregnancy rate. So what kind of stimulation protocol should we be following? So natural cycle will give you only about 3.3% pregnancy rate. This is also a point where you can tell your patients. A lot of patients come forward and say, why do you want to stimulate our ovaries? Why can't we do a natural cycle? The pregnancy rates are very poor. Using only clomiphene, which is what is done by most doctors, the pregnancy rates are as dismal as 9.5%. So if you keep doing clomiphene or just letrozole cycles, not use gonadotropins, your pregnancy rates are going to be poor. If you add gonadotropins, it jumps straight away to 13-14%, which is a decent pregnancy rate to take back. And of course, if you use only gonadotropins, it starts from as good as 17, going up to even 20, 25, and 30%. What about number of follicles? Do number of follicles count, or monofollicular genesis is good enough? So again, we come back to the same 2019 cycles, a huge number. So obviously the data coming out of such a study is a very robust data. They said anything more than 2 is good. So here, if you look at this slide, it is shown that if you have 2 follicles or if you have 3 follicles and you compare this to a monofollicular genesis, the pregnancy rates are higher with either 2 follicles or 3 follicles, which in IUI is really God's word. You have to have either 2 follicles or 3 follicles. Now, we had said that letrozole is very good. At the same time, we are saying letrozole has monofollicular genesis. At the same time, we are saying you need multifollicular development that can only be achieved when you combine letrozole with gonadotropin therapy. So, is more always better? Is there any place where less is also good? Yes. Sometimes less is also more. So when the sperm counts are between 1 to 5 million post-wash and there are no sperm defects, minimal or no ovarian stimulation improves the IUI pregnancy rates. Look at it logically. The number of sperms are very few. You would not, and each follicle or each egg that you put out there will require a certain number of sperms to fertilize it. Now, if you're going to have some 5 or 7 follicles or 5 or 7 eggs over there and give only a small number of sperms, those sperms may not be able to fertilize any egg at all. So, in severe male factor, and even when you're doing a donor insemination, minimal stimulation probably works the best. So, to summarize the ovarian stimulation, maximizing the number of quality oocytes is the single most factor for success. Pregnancy rates are good with 3 as compared to 2 as compared to 1. Beyond 3 follicles, no substantial increase in the pregnancy rates and the complication rates start to increase from there. And when gonadotropins are used, it should be used on a daily basis. Again, we have to understand the concept of the FSH threshold and the FSH window. If you're going to use gonadotropin, it is best that if you use your oral ovilegins from day 2 to day 6, after that from day 7 to day 9, day 10, or even beyond, you use your gonadotropin so as to widen your FSH window. Or you may use your gonadotropin from the very beginning itself. But using gonadotropins a day 3 or a day 8 or on alternate days may not have the same good effect as compared to using gonadotropins on a daily basis. What about GnRH analogs? Why should we use GnRH analogs? Now it has been shown that in stimulated IUI cycles, a premature LH surge may happen in 25 to 30%. We know that if a premature LH surge, which is defined as an LH more than 10 IU per liter, if this happens, the progesterone rise will happen. The follicle will go bad and a pregnancy rate will be lower in such cycles. So this premature LH surge is what we are scared of. And that is why we use a GnRH analog in an IVF cycle as well. So by that rule, we should be using a GnRH analog in every single IUI case as well, because a premature LH surge can always happen. Now, these are some fantastic studies which said premature LH surge happens in almost 25 to 30% of stimulated IUI cycles, and higher pregnancy rates were found when the GnRH antagonist was used in gonadotropin superovulated IUI cycles. By the words, gonadotropin stimulated IUI protocol. Adding GnRH antagonist to IUI cycles significantly increased pregnancy rates in multifollicular but not monofollicular cycles. So there is no major, it does improve the costs considerably. You don't get any major improvement out of using a GnRH analog for every single patient. You have to use it for only selected patients and better to use it for multifollicular growth. So when we are talking about using gonadotropins, we do want a multifollicular growth. So when you use a lot of gonadotropins and you're having a multifollicular growth, probably using a GnRH analog in that case or an antagonist in that case probably would improve your success rates. But when you have lesser follicular development, do not bother about a GnRH analog or specifically an antagonist. This is not going to improve your pregnancy rates. What about the ovulation trigger? When to give the trigger? Is there a specific time? Now, the dictum has been that if you're using gonadotropins, you can give the trigger at a slightly earlier stage, that is 17 to 18 millimeters. But if you're using only oral ovilegins, especially tummy citrate, you should allow the follicle to grow a little more, maybe a 20 to 22 millimeter follicle, and then give the trigger. Because if you give it too soon, again your pregnancy rates will be not very good. Does size matter? We've always traditionally looked at the follicular size only, which is not wrong, which is not bad. But is size the only factor we need to consider? Probably no. Perifollicular flow is also a very good thing because not only do we need to look at the number of follicles, we need to look at the quality of follicles. Why is the quality of follicles important? Unlike an IVF, we are not going to be able to extract that egg and figure out if that egg is of good quality. So we need an indirect parameter to know that the quality of the egg inside that follicle is good. And these Doppler findings are very good in telling you that the quality of the oocyte inside that follicle is fine. So perifollicular flow, you see this, there's a very nice fire-like ring which can be seen all along two-thirds of the follicle. This is the right time for giving the trigger. And here in the other picture, you see the peak systolic velocity uh, being seen of more than 10 per centimeter per second is what is a good parameter. Even if you're not looking at the PSP, at least this perifollicular flow is a very easy thing to do and can be seen on most machines which have Doppler facility. This is a very nice study done by our beloved seniors, Dr. Sonal Panchal and Dr. C.B. Nagori, and they have shown that IUI success rates can be dramatically improved. And they've spoken about conception rates of 32% and 27% when they looked at Doppler studies and they looked at the perifollicular flow and the peak systolic velocity. So please start including Doppler studies in deciding when you want to give the trigger. What is the best trigger? Why can't we do a spontaneous LS search as compared to an HCG? One, there is a technical difficulty. If you don't know when the surge is going to happen, you can't plan for the IUI. The rupture may happen at odd hours. The rupture may happen on a weekend when your clinic is closed. And then you would need to either work weekends or the success rate of the patient would get compromised. So it's been shown that an HCG trigger or a trigger is much better than allowing a natural LS surge. What about recombinant HCG versus urinary HCG? Again, it's been shown that both are equally good. They have similar ovulation rates, they have similar pregnancy rates, and of course, when do you trigger? Each clinic would have its own protocol, but you can trigger somewhere late in the evening and plan IUI after maybe about 36 hours or so. What are the other factors that we should be looking at before planning an IUI? Endometrial thickness. So, is endometrial thickness important? How thick is too thick and how thin is too thin? It says that there is no evidence for an association between endometrial thickness and pregnancy rates. Of course, we do know that even in an IVF, we say that an endometrial thickness above 7 mm is good. Similarly, in an IUI as well, taking an endometrial thickness above 7 would probably make more sense. You normally see endometrium thickness below 7 mm? No, you don't. So if you do have a patient with an endometrial thickness of less than 7, your alarm bells should ring. Am I dealing with a case of Asherman's? Am I dealing with a case of endometrial tuberculosis? If you ruled out all those factors and yet the endometrium continues to remain less than 7, you are most welcome to go ahead with the IUI or IVF. And so many times we've seen pregnancy happen in the thickness as low as 4.5 and 5 mm as well. What about the endometrial pattern? We know that in the follicular phase, we have a triple layer pattern. So they're saying that you should be looking at the triple layer pattern. If in the follicular phase you're finding a homogeneous pattern, probably that endometrium is also not a very good endometrium. So a triple layer pattern in the follicular phase, and once you've given the trigger, you will find with the progesterone a more homogeneous pattern coming in the endometrium. This is what is an ideal situation. So triple line endometrium on the ultrasound after ovarian stimulation before on trigger has been associated with an improved pregnancy rate. What about endometrial scratching? Now, in the years gone by, our seniors would do what a DNC. We presume that that endometrial scratching was what brought about so many pregnancies. And the old timers would say that, we've done a DNC and the patient got pregnant. We never understood. And to a lot of times, we even, kind of looked down upon this DNC per se. But even in an IVF, of course, the jury is still out, and we still don't know whether endometrial scratching really improves implantation in an IVF or not. But yes, there are some studies which say that endometrial scratching does work. Similarly, this particular study says endometrial scratching before an IUI, is it time to reevaluate? And the study says that you should do a scratching and the pregnancy rates improve. Of course, what I don't agree with in this particular study, they say you should do the scratching in the same cycle in the follicular phase in which you're doing the IUI. Now, that probably is taking things a little too far. And we know trials change, times change, studies change, and their entire output changes. So, probably we would need to take this with a pinch of salt. But maybe in the prior cycle, if you're really desperate, you could do an endometrial scratching on day 21 and then do an IUI the next cycle. What about the timing of insemination? So, what is the rationale of doing an IUI? That you should have as many viable sperms as possible at the time when ovulation happens. We know that the oocyte may not survive beyond 12 to 24 hours. And if the IUI is done too late, then the pregnancy may not happen. So here the study says that a short HCG IUI gap of about 32 to 34 hours gives you a better pregnancy rate as compared to a long HCG IUI gap of 36 to 40 hours. Of course, in the last couple of months after the lockdown, that various discussions have been happening in IUI forums and webinars. There are some people talking about doing an IUI even early as 24 and 30 hours. But this is a standard thing that we do about 32 to 34 hours is what most clinics will be following at this point. What about semen preparation techniques? Do semen preparation techniques affect? Now, most importantly, period of abstinence. All these years we've been telling our patients that you should have an abstinence of more than 2 days, but less than 7 days. And that is the best semen quality that we get. Again, times have changed, guidelines have changed, and now we are saying a short abstinence makes much better. Even in IVF, sometimes we are saying that let the husband give two semen samples on the day of egg collection, especially if the sperms are not very good. And the second ejaculation on that particular day might give you better sperms than the first ejaculate. So here as well in an IUI, keep a short abstinence period of less than 2 days, and that will give you a better pregnancy rate. So what about the timing of preparation? Now, with all our busy practices, I'm seeing a patient in my clinic. A patient has come for an IUI. The andrologist or the embryologist collects a semen sample, starts doing the preparation. After some time, he gives you a call saying, "Sir, the preparation is ready." And you're seeing one more patient and one more patient, and maybe doing an embryo transfer and so on and so forth. And you think that, okay, see, the sperms do survive for 24 hours. What is the harm if I do the IUI after 2 hours or 3 hours? The sperms are not going to die because I've used the best possible media. Does that timing really matter? So it's been shown that semen collection to sperm wash should be a maximum of 30 minutes. Sperm wash. So after having done the sperm wash, to the IUI should be done ideally immediately. So the moment the preparation is finished, go up and do the IUI. And from the time that the husband has given the semen sample to you doing the IUI should not be more than 90 minutes, which is a very, very tight schedule. So if you're calling someone for an IUI, make sure you keep yourself free at that point in time and ensure that the IUI happens within 1.5 hours from the point of collection. What about the technique of preparation? So a normal male factor, where no major problems are there, do a normal swim up. If you have problems with these sperms, then do a density gradient. Why? Earlier again in an IVF, we were doing density gradients for most patients. And you get a cleaner catch with a density gradient. And why not do density gradient for all semen samples? The more you're going to churn those semen samples, the more those sperms are going to get damaged. Reactive oxygen species will be generated. That's not what you want. You want more careful and gentle handling of these sperms. So, in a normal swim up, the sperms are not churned or centrifuged at all. So as far as possible, keep a very minimalistic approach to the semen preparation. Of course, if the sperms are bad, a lot of abnormal sperms, a lot of debris is there, then you probably will have to resort to a density gradient. What about the technique of IUI? Whether we should use an ultrasound or just a blind technique. For non-difficult IUI cases, you can as well not use an ultrasound. Most of us are not using an ultrasound or doing an IUI insemination. In my practice, I try and have the patient having a full bladder when I do the IUI, like we do in an embryo transfer. The concept is the same. That when the patient has a full bladder, the uterine axis gets straightened and the catheter will go in more easily. There will be less trauma during the procedure. So no USG guided, keep a full bladder. Type of cannula, it is important that it should be a soft cannula. So any of the good cannulas should be all right. How do you know that the cannula is good? It is best to do a sperm survival in the cannula. So once you've done the semen preparation for a particular patient and you've done, say the IUI as well, take some amount of prepared semen sample and draw it into that cannula and leave it inside your incubator for 24 hours. Also keep the same semen prepared sample in your test tube outside in that incubator for the next 24 hours and compare the two after 24 hours. Now we say that after semen preparation, 75% of the sperms should be alive. So they should be alive in the same numbers in your test tube as well as in your IUI cannula. But if you find that all the sperms have died in your IUI cannula, then you know that this cannula is toxic. This cannula should not be used. So that's a very simple way of finding out. What about the position of the patient? Personally, in my clinic, I keep a kind of a I keep a bit of a head down sort of a position for the patient, wherein the IUI sample, once put in, goes towards the fundus of the uterus instead of kind of flowing out. If the head is up, then the sample can as well flow out of the cervical canal. So that's something. Rest post procedure, it's not been shown that any major rest is required. Maybe a 5 to 10 minute lying in the same bed, and then the patient can as well go up, get ready, and leave your clinic. An extended lying down of half an hour or 45 minutes is probably not required. What about single or double IUI? The debate continues to rage, and there are studies after studies which talk about single IUI probably being more beneficial, which is of course true. That single IUI is all right for most IUI cycles, and here there is a systematic review and meta-analysis which says single IUI is good enough. Double IUI does not give better results and it involves more cost and stress to the couple. Single IUI should be preferable. But should you take that statement with a pinch of salt? Is that the truth for every single patient? Probably not. So, when should you be doing a single IUI? When you have a single follicle, then probably you do a single IUI. And the follicle has ruptured on the day of the first IUI. You've gone ahead and done an IUI, and the follicle has ruptured either before or just after. When should you be doing a double IUI? If you've got multiple follicles, then probably you need more sperms to be available around the eggs, and probably a double IUI would make more sense. So probably if you're using a lot of gonadotropins, doing a double IUI would make more sense. Follicles didn't rupture on the day of IUI. So you've done a single IUI, the follicle hasn't ruptured, you've called back the patient the next morning, and probably at that point in time, the patient says, oh, you know what, I had pain just a couple of hours back. Probably it makes more sense for that patient to go undergo a second IUI. In my clinic, I routinely follow a practice of if I'm using a lot of gonadotropins, we do two IUIs. If you're using only letrozole, I don't use clomiphene citrate, then we go ahead with a single IUI. So to summarize, letrozole has better pregnancy rates than clomiphene. Gonadotropins would give better success than oral ovilogens. Antagonists may be used in multifollicular development and trigger at 20 millimeters for oral, 18 millimeters for gonadotropin, with Doppler features being used. Trigger with HCG is better than using a spontaneous LH surge. Endometrium of more than 7 is better, but if the endometrium is less than 7, don't worry. Only investigate as to if there is a reason for the endometrium being less than 7. If there is no reason, please go ahead. Our timing would be about 32 to 36 hours post ovulation. If no ovulation, so timing of IUI would be 36 hours post trigger. If no ovulation happens, repeat after 24 hours. And technique of preparation, normal male factor swim up, and for the others, you do a density. Timing of insemination should be within 90 minutes of collection, and routine ultrasound guidance is not required. And single IUI if monofollicular, double IUI if multifollicular. Thank you so much for a patient hearing.
Rajiv, that was a great lecture, quite an exhaustive one.
Thank you, Kiran.
Excellent lecture. Now, a couple of questions from my side. Okay, so do you agree, or you showed it that in Western world they give a trial of IUI till 37,
Right.
isn't it? And do you think in Indian context, where we expect the ovarian reserve to be little on the lesser side, what do you expect? At what age we should say cut off, or should we add AMH to that?
I definitely, first of all, yes, various studies have shown that the ovarian reserve is at least 6 years worse in the Asian and the Indian population as compared to the Caucasian population. We definitely should be using AMH for every single patient. I particularly feel it might be an overkill, but it gives us so much of information. If the patient is poor, use an antral follicle count.
Mhm.
Personally, I would say less than 35 years, do an IUI. above the age of 35, it's not that everyone needs to be pushed to an IVF, but definitely that discussion needs to be opened up, saying that, look, there are problems. Your success rates may be lower. Would you like to opt for 3 cycles of IUI and then move to an IVF, or an IVF directly? Even if you're doing an IUI, don't make it like a one IUI 1 year kind of a program. If you're doing it, do it back to back. So in 3, 4, 5 months, you're aware whether it is giving you a pregnancy or not. If not, move to better treatment.
Uh, when do you cancel an IUI cycle? Do you,
When I
or there is something like you cancel the cycle?
see, technically, no, I would not cancel an IUI cycle. The possibilities where we would need to cancel an IUI cycle is A, if for whatever reason we've given some gonadotrophins and this patient is hyperstimulated. And obviously, then we cannot go ahead with an IUI. Such a patient, we always counsel them that shift over to doing an IVF. And we've had some brilliant results from an IUI being converted into an IVF cycle with hardly any money being spent in ovarian stimulation. Of course, if the patient does not agree to transferring to an IVF cycle, this cycle should be cancelled. Again, we have sometimes some patients wherein we've used gonadotrophins, but the cycle is just not progressing. In my opinion, for example, if I've started from a day 5 and we've gone on to day 11, day 12, and we're seeing that those follicles are still very small. Sometimes it happens with women with PCOS. I prefer, instead of continuing the gonadotrophin at that point in time, canceling the cycle, coming back and starting the gonadotrophin a little earlier in the cycle. That I feel gives me better results than trying to prolong, because then that patient produces only one follicle at the end of maybe 15 to 20 days of stimulation, wherein the cost benefit ratio is not achieved. So I probably would go ahead and cancel in those kind of scenarios. Kedar, are you there?
Yeah, I think he's stuck. We'll wait for some time.
If say colleague of yours calls you and says that I have
Sorry, sorry, Kedar, I lost the
hello,
question.
hello,
Yes,
Yeah,
Kedar.
hello, Dr. Ganla. You can just turn off your video. All right.
hello,
Yes, yes, Dr. Kedar.
hello. Can you
I
enter?
can I can hear
If
you.
a colleague of
Wait, hold on. Dr. Ganla, Dr. Ganla, there is some problem with your internet. I think your video is stuck now. Yeah, hello, doctor. So there are a few more questions I can see in here. So I'll just ask you the questions, okay?
Yes, please go ahead.
Yeah. So Dr. Kavita from Delhi, she's asking timing for IUI preferable. What is the preferable timing for IUI?
So what we try and do is we give the IUI, say the trigger, say Monday evening, and after 36 hours, that's on Wednesday morning, we call the patient for an IUI. We will do the IUI irrespective of whether the ovulation has occurred or not. First thing in the morning, we will finish off the IUI. Then we call the patient the next day. And we also ask the patient, or sometimes we also make the patient wait till the evening. So say, for example, I've done the IUI in the morning at 9 o'clock. By 4 o'clock, it also still hasn't ruptured. We call the patient back the next day. The second IUI only happens if the ovulation has occurred or when the ovulation has occurred. And then we corner it from both sides. But otherwise, as a standard, about 36 hours.
Okay. Now, did you answer the question which I asked you? How to convert an IUI cycle into IVF cycle?
See, what we do, Kedar, is obviously most of such patients are having a lot of gonadotropin therapy. If an antagonist has not been given for such patients, definitely an antagonist should be given so as
I
to
will give you. I will give you example. Somebody has got a 4 to 5 follicles of 12 to 14 millimeter on each side. Now today is day 8 of stimulation. Okay.
right.
Now you have to tell him how to convert this patient from IUI to IVF. How would you start?
See, Kedar, honestly, with 4 follicles, I wouldn't even probably want to convert to an IVF. I would probably at this point in time start talking, saying that maybe if the number of
Four,
follicles had increased, even with 4, I wouldn't convert to an IVF.
no. 4 to 5 follicle on each side. I said.
Sorry, on each side. Okay, fine.
Yeah,
So
yeah,
I would, okay, fine. So, on day 8, I would probably look at the E2 levels. If the E2 levels are pretty decent, I would probably give an antagonist at this point in time because I don't want a premature LH surge to happen. A. B. I would step up my gonadotrophins now. Now that I've started committing towards going to an IVF, keeping to a low gonadotrophin mode, especially with an antagonist, would probably make the E2 fall. These patients are very likely to have a spotting starts to happen. So go full out, increase your gonadotrophin dosage, start with antagonist, and then as you would do an IVF cycle, monitor these patients to a 17, 18 millimeter size, look at your perifollicular vascularity, decide your trigger, and then take the IVF forward.
so somebody who is 50 kilometers from you, you will tell him to give antagonist in the evening. Next day morning dose to be stepped up. Give antagonists in the evening. Third day do the scan and tell you, and then you
Right.
will tell him how to send the patient for antagonist. Okay. What is your opinion take on natural cycle donor insemination? Husband is azoospermic young woman. Okay,
Right.
and there are a lot of things now been talked about doing a natural cycle for donor insemination. Do you think it's a good approach, or do you think it's not a very correct approach?
When clomiphene was around, I would probably have said doing a natural cycle donor insemination would be very nice. Theoretically, it does sound nice that there is no reason for us to even stimulate the ovaries at all. But I personally, on whatever studies have shown, letrozole has not shown to be having any side effect or any problem per se. So personally, if you ask me my opinion, I would always want to add a letrozole, saying it can only add some kind of a benefit. It would not take away anything from my stimulation or reduce my pregnancy rates. So personally, I would definitely at least want to add a letrozole. Theoretically, there is no harm in doing a natural cycle donor insemination.
So there is a difference between the what you know and what is you practice. A little bit there is difference according to the patient convenience and from your monitoring side.
Yes.
Another quick question: when you add antagonist to IUI cycle, okay, for doing an IUI, to reduce the cost, there are lots of paper talking about half ampule of antagonist or starting an antagonist only 1 day later, not at 14, maybe
Right.
1 day later. Do you
Right.
think these are good ideas, or sticking to the original plan of 14 millimeter is better?
I think when you've used so much of gonadotropin, there is
Uh,
no point trying to mess around with things. You go a little later, and in some patients, an LH surge does happen. Then trying to explain to the patient what you were trying to do and what you ultimately achieved doesn't make any sense. So if you've committed yourself to a full gonadotropin cycle, saying I'm going to use an antagonist, go with whatever is the traditional protocol. At least at 14 millimeters, give your antagonist is what I would
okay.
probably feel.
Okay. So and then give antagonist every day, right? Till
Yes,
18
yes,
millimeter. Yeah.
yes,
Okay. Now just a very theoretical question. If you do a perifollicular blood flow, okay, after giving letrozole, and you find that the blood flow is not very good, okay.
Right.
So what can we do about it? I'm just asking.
See,
I'm just asking.
so
It's like out of the box.
right. So what we do is we in the first, if this is my first cycle, I'm going to be looking at the perifollicular flow. I would probably keep following this to say, okay, I don't want to give my trigger today. I'm going to wait for one more day and see if the perifollicular flow becomes a little better. Then I'm going to give it my trigger. So that is how we work out the first cycle. Yes, sometimes good things happen. Sometimes things may not work out, and a premature LH surge happened, and the follicle ruptured, or something might just go wrong. Then what I do is in the next cycle, I definitely add my gonadotrophins because then I want a better follicle to be prepared. And that is how we talk to the patient, saying that, look, this follicle wasn't very good, and that is probably why things went wrong. Let's add gonadotrophins. And we do find that the follicle is much, much better. So that's how I would work it out.
In your indications of IUI, you did not mention any indication on patients with decreased ovarian reserve or low AMH. According
Right,
to you, should they be given an opportunity for an IUI, or
right,
should be taken up for IVF? Or if at
right,
all, if you want to do an IUI, should you give them a pre-treatment with androgens?
right. So if the patient leaves the decision on to me, saying, Doctor, I have poor ovarian reserve, what is it that you would like to do for me? I would say go in for an IVF directly. Don't waste time. The pregnancy rates are going to be better with an IVF. Having told them that, I also tell them that look, there are some patients who are committed to an IVF but get pregnant naturally. So our entire concept of poor ovarian reserve and our understanding of AMH and AFC and egg quality is probably still not as good as we would have wanted it to be. Not because we are ignorant, because nature and science and God hasn't provided us with that information yet. So as some patients get naturally pregnant, some patients can get pregnant with an IUI as well. Probably also because one tries intercourse 12 months in a year, one tries IUI 4 times in a year, but no patient is going to undergo a stimulation 5 times or 4 times or even 3 times in a year. So probably out of the sheer number of tryings, sometimes pregnancy happens. So if someone says, can IUI never give a pregnancy in a poor ovarian reserve? I would say no, it does. A lot of times an IUI has managed to give a pregnancy where IVF has not. Sometimes patients get pregnant with natural trying as compared to an IVF. Does that mean that I start advocating normal trying or an IUI to every patient with poor ovarian reserve? No, that is not what I would do.
So, what is the ultimate take?
My ultimate take is IVF is what is the best. If the patient has come with a poor ovarian reserve, and I'm saying that, okay, why don't we try and improve your ovarian reserve? Let's try androgens. Let's try some kind of antioxidants. Maybe the ovarian reserve might just get a little better. While we are waiting for these things to happen, you have a choice of doing a natural trying, or you can do IUI for 3 cycles. The 3 cycles will not make you age from 30 to 50 or bring the sky down on your heads. In these 3 cycles, if you haven't gotten pregnant, maybe your egg quality might get a little better. In the 4th month, we do an IVF. That's what I would tell them.
Now, Raju, my questions are remaining still three questions for you, but I wish to go to the what people have asked you. One of them is asking you that you're doing an IUI and there is a difficulty in negotiating the cervix. How do we proceed?
Okay. The most important thing is the kind of catheters that we are using. Every person has different kind of catheters. So I use a Gynetech catheters. I have used every kind of catheter possible, the 50 rupee one and the 70 rupee one and the 30 rupee one. And then I stuck on to this because I find that catheter the tip very soft, very malleable, and it has a natural curve, which we find in the embryo transfer catheters as well. And I felt that negotiating with a sort of a curved catheter tip becomes more easy as compared to something which has a straight line. So using a better catheter. Two, if you already have a catheter in your hand and you obviously can't go and buy one, you make sure that this patient has a full bladder. If the patient right now has an empty bladder, the moment you make the bladder full, it's going to make the curve a little better. and you will find yourself negotiating the os much better. If that is also not helping you, sometimes then holding the anterior lip of the cervix with a tenaculum or an Alice and gently giving a traction. Don't give too much of a traction because it can then cause a uterine contraction, and the sperms can come out. These measures most usually help. Sometimes it also helps stepping away from it, taking a break for 5-10 minutes, letting the patient relax, and you also coming back with a more fresh mind than trying to constantly keep at it at the same time, because you're getting frustrated, you're wanting to finish the procedure, and you're not thinking the right way, and you're creating a false passage in that time. So step away from it. Let the patient probably also have a cup of tea, or a glass of water. You have a cup of coffee. Come back and try again. The bladder might just get a little more full, and you might be able to achieve a success. If
On the
nothing
la-
else is working, sorry.
on the lighter note, you could just go and see a webinar for 10 minutes and come back.
It's not that we've not used,
Just
a sound or a dilator, even in a very
uh,
difficult IVF case, but try and keep it to the absolute last. Don't use it. But trust me, if you use a good catheter and you're a little patient and you make sure that the patient has a full bladder, it is very, 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 very unlikely that you will have to come down to using a sound or a dilator. It is going to be very unlikely. There is, in fact, one study which even said that they used misoprostol and the pregnancy rates actually became better. I don't know how it happened, because misoprostol would have caused uterine contraction. But if that study were to be true, then probably if nothing else is dilating the cervix, you could probably put in a misoprostol, wait for an hour or so, remove the misoprostol, and then try and doing the IUI. I don't know how good that idea is. I've never tried it myself. I've never had to, but just a theoretical thought.
well, I have tried it, and the patient actually gets a lot of pain and comes back with the bleeding. The
Right,
entire endometrium is destroyed.
right.
Maybe I could add a little more suggestion. Maybe you, with a great difficulty, you finish the IUI. When you take out the catheter, there is blood on the catheter. Okay, so the most important is to write down on your paper that this cervix is a difficult cervix.
Right.
Maybe in the next cycle, either of IUI or IVF, you will do a dilatation or a
Of course, yeah.
hysteroscopy, and then think about how to reduce it. Somebody is asking, they want to know Dr. Rajeev Agarwal's pregnancy rate with IUI success rate.
Okay.
Uh,
So with tablets, it's been as dismal as 7 to 8%. We use a lot of letrozole and gonadotropin,
they
wherein the
want to
success
know
rates are.
they want to know with your charm and you whatever you suggested, what is your pregnancy rate?
I want to know the name of the person who's asked the question.
I will ask, I'll tell you 1 minute. I'll tell you. It is from Bharti from Mumbai. Okay. The charm is added by me, but Bharti is asking your success rate.
So with letrozole, the pregnancy rates are only about 7 to 8%. We do a lot of letrozole and gonadotropin cycles. We are achieving about 13 to 15%, I would say. I'm a great fan of using short protocol for IUI, to be very honest. And I have a success of almost 25 to 30% using a short protocol cycle. And I absolutely love it. As I said, we plan the cycles from beforehand itself, wherein we are saying, okay, first cycle tablet, second cycle tablet plus gonadotropin. In the third cycle or the fourth cycle, are we going to do an antagonist for maybe a severe PCO? Or we feel that we can push this patient to a short protocol? We definitely would want to do something like that in the third or the fourth cycle. And the results are brilliant.
There are lots of people in the audience may not know exactly what is short protocol.
Right.
Will you be
So in
kind
a
enough
short
to explain? Yeah.
short
Yes.
protocol, what we do is we use a GnRH agonist in a short dose, small dose from the beginning of the cycle, along with gonadotropins from the beginning of the cycle. So what I use is leuprolide acetate 0.25 from day 2 of the cycle itself, with a urinary or any other HMG or FSH of 75 from day 2 itself. We do like an IVF. On day 5, we do an E2 level just to see what the values are like. In an IVF, if I were to do a stimulation, I would be looking at, if say it's an antagonist cycle, a value of more than 500, because I want a lot of follicles. In an IUI, I'm looking at definitely 100, not more than that. If I see a lot of follicles developing on day 5 itself and the E2 is going up, I will stop my IUI right there itself, or tell the patient that, look, we are moving towards a hyperstimulation. Are you going to go into an IVF after this? But assuming everything is going absolutely all right, we continue with 75, no dosage change, nothing else is required till 17 to 18 millimeter follicle is developed. And you'll find that by day 9, fantastic 3 to 4 follicles of 17, 18 have formed. Give your trigger. I would do 2 IUIs instead of 1 IUI for such a patient and walk away. With this protocol, we've had a very good success.
So what you're
And
trying
I'm
to
sure the
do
next
is,
question would come: what my twin pregnancy rate is been? Our twin pregnancy rates have not been any higher than my IVF twin pregnancy rates. It's not that every IUI patient who's had a short protocol lands up with a twin. Same 15 to 20% is what they land up with. How many cycles do we really need to convert to an IVF? I would say we convert maybe 1 to 2 or 3 per year, not more than that. It is not that all the cycles get converted, but yes, I would agree. Although this is not a theoretical teaching, which I would impart to everyone, that we do IUIs even when the follicle numbers are more than 3, sometimes even going up to 4 and 5. Personally, what we've seen is that multiple pregnancies don't happen. But in an Indian setting, we do want to give them a pregnancy as soon as possible and in the most cost effective manner. So, giving them a pregnancy faster, I feel, is more cost effective than going through multiple IUIs, some 5, 7, 10 IUIs going on, or pushing them into an IVF.
a lot of people have asked you, how do you time your IUI? So you said you give the SCG in the evening, and you told that next day morning you
So
call them.
if I am looking at if I'm looking at doing 2 IUIs, what I will do is I will call the patient on a Monday morning. The scan having been done, we decide that, okay, the trigger now has to be given. In the morning itself, we will give the trigger. We will call the patient the next day around 3 p.m. in the afternoon, do the ultrasound, understand whether a rupture has happened or not. Irrespective, we will do the semen collection and we will do IUI. So by about 4 or 5, just before we are leaving the clinic, we finish off the IUI. Now, say for example, the patient has already ruptured, then that single IUI is good enough for us. If the patient has not ruptured the follicle at that time, we call the patient back the next morning. And the next morning, only once we've documented the rupture, do we go ahead with a double IUI. If the patient has not ruptured the follicle that time also, we ask the patient to wait afternoon, evening, or even the next morning and only do a second IUI at that time. So that is how we do a double IUI. If we are doing a single IUI, again, we give the trigger in the morning, call the patient in the afternoon, or we give the trigger in the evening by about 7, 8 o'clock, and then call the patient after about 36 hours.
How does one monitor the cycle? Is it the only ultrasound, or you have to do in E2 levels in your IUI practice? Is
Right.
a question.
If you ask me, ultrasound is of course mandatory. It's most important. But even on an ultrasound, it is very important to call the patient on a day 2. A lot of people fail to call the patient on a day 2 of the cycle. You miss out some functional cysts. If the functional cyst is there, you have a very thick lining of the endometrium. You know that this patient will not respond to your gonadotropin or the oral ovulogins or whatever else you want to give. Cancel the cycle, give a cycle of OCP, call the patient back the next cycle. That's number 1. Number 2, you get to evaluate the antral follicle count in that particular cycle. You can still decide what kind of a stimulation you want to do for that particular patient. In case you've thought of another protocol, but this cycle you see something different, you can always modify your protocol. And thirdly, sometimes if you've missed seeing a functional cyst on day 2, and you've called the patient back on day 8 or day 9 or even day 12, that same cyst might be persisting, and then you're absolutely confused whether it's a follicle or a persistent cyst from the previous cycle. So day 2 scan is very important. If we are using a tablet cycle, we call the patient straight away back on day 9 or day 10 if it's the first cycle, and I don't know how this or when this patient makes the follicle. So we start the first one usually by day 9. If we are using gonadotrophins, we start the gonadotrophins from day 5. then definitely by day 9 we want to start doing the follicular study. If we are using a short protocol, then day 5 itself we call these patients, and then maybe alternate days or whatever we start calling the patient. But from day 9 onwards, we usually call the patient every single day, unless you've seen the follicle of maybe 12 to 13 millimeters. Then you skip one day and call the patient the next day. Do not leave it to your lot of doctors, gynecologists are referring outside to diagnostic clinics for their ultrasounds. Do not leave it to the ultrasound practitioners to tell you when you should be calling back the patient. You must decide when you need to send the patient back for a follicular scan. A lot of times they will tell you that call the patient after 3 days, and by that time the follicle is already ruptured. So don't do that. Monitor it yourself.
Agreed. That is a very, very valid point. Uh, what should be, how do you decide the starting dose of gonadotropin in a patient for IUI? Starting
So
dose.
either I'm using either oral ovulogins plus gonadotropin, or I'm using a short protocol, or I'm using an antagonist protocol. In the oral ovulogins with gonadotrophins, I only go to 75 IU. I normally started from oral ovulogins from day 2 to day 6, and the gonadotrophin from day 5. I normally give it only till day 9. So a combination of the two. After day 9, we simply follow up and see. Now, based on the first cycle, we decide if we are going to increase the amount of gonadotrophins or not. So say, for example, after having given day 9 injections, the follicle on day 10 or day 11 is still very, very small. Then one has to go back and say, okay, is this patient a severe PCO? Have I given my metformin? Have I given my supportive therapy? Have I asked her for weight loss? What do I want to do the next time? Do I want to go to an antagonist protocol where she might hyperstimulate? Or do I want to increase the amount of gonadotrophins, maybe in the number of days of injection? So maybe instead of day 5 to day 9, I want to go from day 5 up to 17 to 18 millimeters. Sometimes you just need to keep trying different protocols till you hit upon the right one. Antagonist protocol, again, is a very good protocol, but what I have found is while in a short protocol, simple leuprolide acetate of 0.25, and you just need one vial, it hardly costs 400 rupees. Along with your 75 IU, gives you brilliant successes. But when you're using an antagonist protocol, 75 IU from day 2 is not enough. A lot of times you have to start from 100 IU, and that has automatically pushed up your cost a little bit. So that, along with at least one antagonist, if not two, is what you're going to require in an IUI cycle. So in a short protocol, 75 IU with 0.25 of leuprolide acetate is what is the dosage. In an antagonist cycle, 100 IU of your gonadotrophin from day 2. If it's a oral ovulogen plus gonadotrophin, start with 75 from day 5 itself.
Somebody wants to have your email ID, so I've told them to look on anywhere on the website and on the
Right.
Facebook. You will find lots of people following you, so there should not be a problem. There are okay. There's one question. Many times the follicle does not rupture after giving trigger, and you call the patient for IUI. What do you do? Do you wait a little longer and then do the IUI? You have answered that what you do is you do the IUI
So,
and call them after 24 hours and check. Is that
right.
correct?
I don't know if the person is talking about a luteinized unruptured follicle syndrome or not.
But
But
why don't you explain?
so if we are going to wait, and of course, once the rupture has happened or somewhere around that, sometimes we've done one IUI, called the patient back, and we are waiting for a second IUI, and the rupture has happened very late. Maybe we've done a second IUI as well because a lot of money has gone into the gonadotrophin therapy, and then we've had to do a third IUI sometimes because the rupture happened very late. But going to the luteinized unruptured follicle syndrome, whenever you experience such a scenario, there are three things which must always come to your mind. A, have you given the trigger at the wrong time? So if you've not correctly assessed that follicle and you've given the trigger at the wrong time, you may land up into a luteinized unruptured follicle syndrome. The other two
Wrong
things you
time.
must do
1 minute. Wrong time means,
pre-
is it even early or late?
early. You've given too early.
Okay.
So then there is a possibility that you might land up into a luteinized unruptured follicle syndrome. Two, are you dealing with a patient of polycystic ovarian syndrome? Because these patients are also notorious. Probably also because you've not made a good follicle. Patients with endometriosis will again have a luteinized unruptured follicle syndrome. Go and look at the prolactin levels. and see if the prolactin levels are very high. If nothing seems to be wrong, this patient is a typical PCO patient. Improve your stimulation the next time, add your gonadotrophins, you'll find a much better follicle, and the follicle will rupture as well.
Maybe you should try a dual trigger sometime. It works well.
Dual trigger as well, yes.
As it works. Now, your questions in the panels are over. Now, I come back to my questions. A little tricky. Uh, do you think microfluidic technique of doing the sperm separation would help in IUI? I can understand. I have absolutely no idea about microfluidics. Only
Right,
I have used in IVF, but there are people
right,
now recommending in IUI. You must have seen in Eshrei, there were
right,
n number of free communications on
right.
microfluidics.
Kedar, I don't know if it really makes sense to increase costs in a low
Cost.
cost scenario. Again, if you really talk about adding other factors, if you go on the Google net and search for platelet activating factor, there are various papers which have said there is a jump of 50% in the IUI success rates by just adding platelet activating factor. But when I ask embryology colleagues, no one seems to be adding platelet activating factor, although there are some fantastic studies. And there are, in fact, no studies which are saying that platelet activating factor does not give you a pregnancy. So, probably, I don't know why again, there is hardly any focus, although there are n number of webinars on, IUI, teaching IUI to people. When you go to a conference, no embryologist, no groups really sit down and talk about how to improve an IUI success rate from an embryology or an andrology perspective. No one talks about the microfluidics and the platelet activating factor and so on and so forth. I don't know, but microfluidics would be a bit of an expensive addition to the whole semen preparation technique. I don't know in the Indian scenario, unless it is fantastically proven, whether I would really want to add that cost.
Then, do you consider as an indication as mild OAT to consider for a double IUI? For
Definitely
doing
so. So definitely so. So if the number of sperms are lesser, we do feel that the number of sperms may not be enough to fertilize that egg, and maybe doing a double IUI would give slightly more sperms over there. So absolutely, I would probably want to do something like that.
now, the next question is a little rapid fire. Okay. Now, what is that formula? Hmm? What is that formula, that charm do you use so that your IUI patients or IVF patients are becoming pregnant? So we'll talk about IUI, post IUI instructions. Okay. So during the IUI process, do you give head load to your patient? Answer is
Yes,
yes
I
or
do.
no. You give
Yes.
head load. Do you give buscopan to the patient?
No, I don't.
Do you recommend giving antibiotics to your patients?
No, I don't.
No. Okay. Do you give atropine to your patient?
No, I don't.
Do you get the consent signed before the IUI?
Yes, of course, 100%.
You confirm the husband-wife relationship as husband-wife.
Absolutely.
Absolutely. Then comes the question: how much bed rest has to be given to this patient?
10 minutes after an IUI, after that, get up, go back home,
No, no,
stay
no,
at
no.
home if that takes.
No, post IUI she has to come and see you, isn't it? For post
Post
IUI instructions. So
post
there when
IUI
she comes,
instruction.
yeah, so she comes to your
Right,
room, right? Now
right.
a typical mother-in-law is going to ask you whether she should take rest at home, and she has
No,
to
she
take a
doesn't need
rest.
to.
So she doesn't need to take rest. Okay,
No.
you have done so much IUI and no rest. Will you change her diet? She wants to know whether she should eat garam, thanda, what?
Normal
Or
diet
you,
which we eat at normal
uh,
diet what we eat at home. Of course, anyone who is trying to get pregnant needs to have a more healthy diet, stay away from fried stuff, less of carbs, more of proteins, and so on and so forth. But it's not that the food, if we are eating normal food at home, that needs to change. But yes, if you're probably going out to a restaurant every single day to eat out, I would probably say cut that out, because that food may not be very good for conception.
okay. And what about exercise? She is little PCO types, little, you told her, Rajiv, that you lose your weight by 10% and then I will take you for IVF. So she asked after the IUI, can I go jogging? Can I go
What
jumping?
I always suggest is if you divide the cycle between the follicular and the luteal phase, during the follicular phase, go all out, exercise as much as you can, use the follicular phase for a weight reduction aspect. In the luteal phase, go for a weight maintenance aspect. So probably just walking is absolutely fine. Don't do any, aerobics and stuff like that. But yes, if you want to maintain, just walk or swim maybe. Even that's good.
No. Swimming, do you agree swimming? Because many
Yes.
people have this fear that the water will go inside and this
No.
chlorinated water. So
Obviously,
yeah.
obviously, there is no
Okay.
scientific basis for that.
Absolutely. Okay. That's what I'm coming to that. And
Right.
would you ask the couple to have intercourse? So they feel that having intercourse will now spoil the whole, because now the ovulation has already happened and the
Right.
follicles, the sperms are gone in time, but Rajeev Agarwal has done the job for them. So now,
Right.
is there a necessary to do intercourse?
This question answers, I guess, all the questions of the bed rest and everything else, because most studies have shown that after IUI and after an embryo transfer as well, intercourse actually improves the pregnancy rates. So there is absolutely no problem. They can go ahead. In fact, sometimes it gives more sperms over there, and the pregnancy rates might just become better.
Hmm. There is something in the seminal fluid which helps in
Yes.
embryo implantation. That's where it comes
Yes.
from. And what about luteal phase, Rajiv? You need a sponsors, so you not tell anything about luteal phase support. Means
Luteal phase
what?
support.
Mhm.
Um, Practically, if you ask me, we're giving luteal phase support for every single patient that we do IUI for. Why am I doing it? Theoretically, it is said that those patients who are having only oral ovulogents, maybe a letrozole, wherein there is no endometrial effect, you may not give a luteal support. But I feel a patient is coming with so much of apprehension, so much of hope. And as I said, studies keep changing all the time. Today, someone says, don't give it. Tomorrow, someone else will say, give it. So when patient has spent so much, spending a little more on luteal phase support, progesterone, of course, no estrogen, does not have any problem. That is true. But if you are using gonadotrophins, especially if you are using GnRH agonists, you must give luteal phase support. That's a must.
Okay.
Oral ovulogents, you might not want to give if you don't want to.
Okay. There are questions coming up now, pouring in all across. They're telling their friends also to put questions to you. Pure gonadotrophins, use of pure gonadotrophins for PCO. What is your take on it? And how many cycles do you require to do to make your patients pregnant? Or when do you move off to the next stage?
There is no difference between using urinary or recombinant HMG or FSH, even for PCO patients. So you can use it as per the patient's requirement and as per the cost of it. And as I said, I don't do more than 3 to 4 cycles of IUI. We start with oral ovulogents, then move on to oral ovulogents plus gonadotrophins, then move on to gonadotrophins only. Sometimes we start with oral ovulogents and gonadotrophins from the very beginning. But whatever it is, 3 to 4 cycles maximum. Thereafter, we switch on to an IVF unless the patient really insists that they want to do another cycle of IUI.
Now, we talked about the IUI, and we will not be coming back to this aspect, and donor insemination aspect is going to remain. So, my one or two quick question to you is, when you decide to do a donor insemination, ideally speaking, where are we supposed to procure the donor sample from?
It has to be only procured from a semen bank. The IVF center or any other infertility center is not supposed to have its own indigenous bank, wherein they recruit donors and they start using those donors itself. It's not right as per the ICMR guidelines. There are qualified proper semen banks available, which are separate from all infertility centers, and the semen sample must be procured only from them, which are anonymous donors who have been investigated, and the semen sample has been frozen.
Quarantine means
Quarantine,
that's
yes.
quarantine. Now, the second one is that I am not staying in a top class city of Calcutta. I am staying somewhere else in a
Right.
village where there is no ART center. So, what would be your advice to them?
For donor insemination.
Yeah.
So if that is the case, you buy yourself a liquid nitrogen can, and there are people who transport these semen samples to your place. You will have to, of course, procure liquid nitrogen, or again, if you can't manage that also, then the person brings the liquid nitrogen to you every week or every fortnight and pours it into your can, which is going to probably be a little expensive for you. But yes, you can have a liquid nitrogen can and keep your donor samples in there.
Okay, some patients request that my husband's sample is very poor. Uh, there is a friend of mine, okay, whose sample is good, or my brother, okay, stays in the family. Such a kind of request when they come, should we accept such request or should we deny?
Absolutely should not be encouraged. One can get into very serious legal problems with such a scenario. Should not be encouraged.
Now there is a patient who says I cannot collect a sample in the clinic. There is too
Right.
noisy, it's too fancy. I get very, so I will collect the sample from home. So in
Right.
that situation, what do you do, Rajiv?
What we tell them that is that they can collect the semen sample at home, although that is not the best thing to do, but they must bring us the sample within half an hour of time, and that they should not collect it by natural intercourse, because if they do that, the semen sample would be lost. So they should try masturbation at home. If the husband is still not able to give it by masturbation at home, there are non-spermicidal condoms which are available, which the couple can use. Of course, you must remember that whenever such a sample is brought from outside, you must get a consent done by the couple that the
Absolutely.
identity of the person giving the sample is not known, and
Mhm.
that they are certifying that it is the husband's sample, and only based on their certification you're taking it forward, and you're not liable for any legal issues if the sample does not turn out to be theirs. It is very important, because sometimes patients do trick these things. They will tell you that they want to use their father's sample or brother's sample. You say no, and then they will bring that same sample from home.
So that's a very valid point. Another thing is when you want to select a donor sample, who makes the choice of the donor semen sample in the sperm bank? Is it you make the selection or the couple has to go and make the selection?
We make this the choice honestly. We take the criteria from the patient as to what is it they are looking at, but of course there are no religious changes. We only look at height, weight, age, eye color, hair color, and the educational background. That's all we look at donors. We don't go beyond that, so those queries or those things are not entertained.
Uh, there are some high-tech laboratory just for this thing that they are extremely good, and people, if you refer them, they're very very happy to go there and select a semen sample according to their requirement. Last question, last and last. Once the semen sample is been bought and you did the IUI, okay, where do you store the consents? How long do you store the consent for?
So
How
right
long?
now we are storing the consents physically, although
Yeah.
that is not the best of things to do.
Okay.
The best thing would probably be to store them digitally, because then they're going to stay for a very long time.
Mm.
Honestly, we've kept consents for the longest possible time. I'm not very sure of the ICMR guidelines for legally how long they need to be kept, but
Mm.
we probably would have them for the last 10 years or more than that.
Okay. So ideally speaking, in the end, when you stop your practice, you're supposed to deposit all of them to ICMR
Hmm.
office, but we really do not know how it is going. So
Right.
it's 1 hour 35 minutes, an exhaustive session by Rajeev Agarwal, and we congratulate you and we thank you for giving such an excellent talk. Thank you,
Thank
Rajiv.
you. Thank you, Dr.
Thank
Kedar.
you,
Thank you.
thank you, Doc Mode, and thank you, Zydus, for providing this lovely platform for us. Thank you. Bye,
Thank
Rajiv.
you. Bye.
See you.
Bye. Bye.
Stay
Bye.
well.